Good day, everyone. We are students of BSN 3-4, and our group will be presenting an overview of the different types of pancreatic surgery. Have you ever wondered how surgeons take on one of the body's most complex and delicate organs? From life saving removals to advanced, minimally invasive techniques, these procedures showcase the incredible precision and skill of modern surgical care. Let's explore the different types of pancreas surgery that change and sometimes save lives. In this report, we will discuss several key procedures, including pancreatectomy, the Whipple procedure, laparoscopic pancreatic surgery, the Beggar procedure, and the Frey procedure to better understand their indications, techniques, and clinical significance in patient care. The first pancreatic surgery that we'll be talking about is all about pancreatectomy.
The first pancreatic surgery to discuss is pancreatectomy. This is a type of surgery where part or all of the pancreas is removed. It is typically done to treat serious conditions like pancreatic cancer, chronic pancreatitis, pancreatic cysts, or injuries to the pancreas. Depending on the case, the surgeon may remove just a portion or the entire pancreas. While it's a major operation, it can be life-saving or significantly improve a patient's quality of life.
Now, let's talk about the types of the pancreatectomy. First is we have the distal pancreatectomy, which is the removal of the body and the tail of the pancreas. Next is we have the pancreatico-duodenectomy, or what we call the Whipple procedure. So this is the removal of the head of the pancreas, port of the duodenum, gallbladder, and the bile duct. Next is we have the total pancreatectomy, which is the removal of the entire pancreas. Last is we have the central pancreatectomy, which is the removal of the neck or the mid portion, preserving the head and the tail of the pancreas. So before the procedure starts, we have to get the pre-operative consideration of the patient. First is we have to do the patient evaluation. We have to get the full assessment including the imaging such as the CT scan and then the MRI. Next is the lab test and then the nutritional status of the patient. Next is we have to get the glycemic control, especially if the patient has diabetes or impaired glucose tolerance. Next is we have to do patient education. We have to discuss to the patient the procedure that the patient will have, the risk factors, and then the expected recovery. And then also we have to explain the possible long-term effects of the insulin dependence after total pancreatectomy. Next is we have to do bowel preparation. This is depending on the surgeon's protocol. And then last is we have the infection prophylaxis. We can give antibiotics pre-operatively.
During a pancreatectomy, several intraoperative considerations are crucial for a successful outcome. First, hemostasis is essential since the pancreas is highly vascular, so controlling bleeding is a top priority. Second, there is the preservation of vital structures. Surgeons must carefully dissect around major vessels, the liver, and intestines to avoid damage. Third, to minimize leakage, especially from the pancreatic duct, meticulous surgical technique is key to preventing anastomotic leaks. Lastly, anesthesia management plays a vital role. Close monitoring of blood loss, fluid levels, and hemodynamic status is necessary throughout the procedure. After a pancreatectomy, careful post-operative management is crucial. Patients require close monitoring of vital signs, drain output, blood glucose levels, and electrolytes. Pain control is typically achieved using PCA or epidural analgesia. Nutritional support is also important. Patients may be kept MPO initially and in some cases may need enteral feeding or TPN if recovery is delayed. If the entire pancreas is removed, insulin therapy becomes essential to manage blood sugar. Drain management is key as well, watching closely for signs of pancreatic fistula like amylase-rich drainage. Lastly, encouraging early mobility helps prevent blood clots and speeds up recovery.
So next is we have the complication that the patient might have after or before the procedure. First is the pancreatic fistula, which is the leakage from the pancreatic anastomosis. Next is the infection if walang proper wound care yung patient, or intra-abdominal abscess. Next is bleeding due to post-operative hemorrhage, delayed gastric emptying. This is very common if the patient has done Whipple procedure. Next is the endocrine insufficiency. This is due to diabetes mellitus due to insulin loss. The exocrine insufficiency or the malabsorption requiring pancreatic enzyme supplements. And then last is we have the anastomotic leak, which is very risk in procedures involving GI reconstructions. So last but not the least is we have the nursing responsibilities. First is we have to do the assessment and monitoring. We have to monitor the vital sign of the patient, the drain output, blood glucose, and then signs of hemorrhage or infection or leakage. And then we can do the assessment for signs of hemorrhage and sepsis. Next is pain management. We can administer prescribed analgesics, and then we have to assess pain levels regularly. We can do support respiratory function with the help of incentive spirometer due to reduce deep breathing post-surgery. Next is we have to do a nutritional support. We can monitor the nutritional intake of the patient and then the weight. We can administer pancreatic enzymes as prescribed, and then we can collaborate with dietitians for diet advancement and diabetic education if needed. And also for the blood glucose management, we have to monitor and manage blood glucose levels, especially if the patient develops diabetes post-operatively. And then also the patient education. We have to teach the patient for the signs of complications, and then we have to explain the lifelong changes if the patient has a total pancreatectomy was done, such as enzyme and then the insulin therapy, and then we can encourage the adherence to follow-up visits to the doctor. And then last is the psychosocial support. We have to offer emotional support, especially for cancer patient or those adopting to challenges or chronic conditions like insulin dependence.
So for the next surgery of the pancreas, we will be talking about Whipple procedure. So Whipple procedure, this is also known as pancreatico-duodenectomy. It is a complex surgical operation that is used to primarily treat cancers and other serious conditions affecting the pancreas, the bile duct, and the first part of the small intestine, which is the duodenum. So in this procedure, the following parts are removed, such as the head of the pancreas, the duodenum, or as I have said earlier, this is the first part of the small intestine. Next, the gallbladder, the bile duct, and sometimes part of the stomach and the nearby lymph nodes. So in this procedure, we have two types. The first one is the standard Whipple procedure, and the second one is the pylorus preserving Whipple procedure, or the modified Whipple. So for the standard Whipple procedure, this procedure involves the removing of head of the pancreas, duodenum, gallbladder, part of the bile duct, and a portion of the stomach including the pylorus. So pylorus is siyang muscular sphincter sa end ng stomach which is connected siya sa duodenum, or again, as I have said earlier, part ng small intestine. So this primarily serves or act as a passageway ng mga food at liquid from the stomach to the duodenum. So, ayun. So, this procedure is typically used to treat the tumors that is located at the head of the pancreas. So, kapag yung tumor, located siya sa head of the pancreas, standard Whipple procedure yung ginagawa. Tapos, the pylorus is removed in this procedure, which can sometimes lead to digestive issues after surgery. So, as I have said earlier nga, yung pylorus kasi, siya yung it acts as a passageway for food and liquid from the stomach na makapunta sa small intestine or sa duodenum. So, if natanggal to, maaaring magkakaroon ng disruption or, yun nga, digestive issues after surgery. Yun. So next naman is the pylorus preserving Whipple procedure. So from the term itself, pylorus preserving, ibig sabihin yung pylorus na nandun na located again sa stomach natin, na left intact siya. So with this, na-help ma-minimize yung possible or potential digestive problems after surgery. So itong type of approach ng Whipple procedure, mas mas preferable siya kesa doon sa standard Whipple procedure kasi it can lead to less complications or ayun. So here are more informations about the Whipple procedure. So after removing the pancreatic head, duodenum, gallbladder, and part of the stomach, the surgeon reconnects the remaining organs to restore normal digestion and blood and bile flow. Unless na lang if tinanggal ang pylorus, kasi yon magkakaroon talaga ng disruption. Kasi wala nang madadaluyan yung food and liquid from the stomach to the duodenum. So magkakaroon na ng medyo mahirapan na, magkakaroon ng disruption sa digestive process. Ganon. So it is most commonly performed for pancreatic cancers in the head of the pancreas. So, kapag yung tumor namuo doon sa head of the pancreas, as I have said earlier nga, ayun, Whipple procedure ang ginagawa. So, it is also used to treat pancreatic cyst, chronic pancreatitis, bile duct cancer, ampullary cancer, neuroendocrine tumors, small intestine cancer, and trauma. So, ayun. So, this surgery lasts for 4 to 12 hours. So, it typically takes 4 to 12 hours para matapos ang surgery na to. Since it's very complex nga, maraming tinatanggal. Tapos, kapag tinanggal, kukonect mo pa, ganon. May mga i-connect pa after that. What I mean. So, ayun. Significant risks includes bleeding, infection, delayed stomach emptying, leakage from reconnection, and diabetes. So, diabetes kasi, di ba? Kasi nagtanggal tayo ng part of the pancreas or head of the pancreas, which, alongside with this, nawala na rin yung pancreatic parenchyma, which is responsible sa insulin production. So, this loss, it impairs the pancreas's endocrine function, disrupting glucose homeostasis, which then will result to pancreatogenic diabetes mellitus or the type 3C diabetes. So, ayun. Hospital stay typically lasts 1 to 2 weeks for recovery and monitoring. So, this is considered the only potential curative treatment for many pancreatic and periampullary cancer since nga ang goal neto is tanggalin na mismo yung tumor doon na namuo sa pancreas. So, it can significantly improve survival if cancer is confined and patient is fit for major surgery. So, here are the things to consider before performing a Whipple procedure to a patient. So, first is we need to conduct thorough nursing assessment including medical history, comorbidities, gastrointestinal symptoms, pain level, and infection. Risk factors such as obesity or smoking. So, upon performing this would ensure or prevent severe complications during surgery. Next is we need to educate the patient and family about the procedure, expected outcomes, potential complication, and post-operative care to reduce anxiety and improve cooperation. So, this would give the patient a heads up about the procedure to be performed. Next, we need to verify blood availability and prepare for possible transfusion due to complexity and potential blood loss during surgery. Then last, we need to collaborate with multidisciplinary teams to optimize nutritional status preoperatively as malnutrition is common in these patients and impacts recovery. For the intraoperative considerations, we need to assist in patient preparation and operative support, ensuring aseptic technique and monitoring vital signs closely, and monitor for hemodynamic stability due to the risk of bleeding and vascular involvement during surgery. So for the post-operative considerations, we need to monitor vital signs continuously as well as abdominal assessment to detect early signs of complication such as bleeding or infection. Next, manage pain effectively using prescribed analgesics and non-pharmacological methods. Then, promote respiratory care, including deep breathing exercises and incentive spirometry to prevent atelectasis and pneumonia. Then, monitor surgical wounds for infections, dehiscence, or hematoma. Upon doing so, we need to maintain strict aseptic wound care and educate the patient of signs of infection. So usually, the abdominal incision is closed with staple, dressing for first 2 days, then left open to air. Then staples are removed 10 to 14 days post-op, possibly by a family doctor. So family doctor yung nagtatanggal nun. Then, monitor fluid balance meticulously, including intake and output, to detect early signs of complications like pancreatic fistula or renal impairment. Then, abdominal drains placed near pancreatic and biliary anastomosis to monitor fluid. Then removed when output decreases and no pancreatic fistula is evident. So some patients may go home with drains and receive home nursing care. Then, glycemic management is critical due to pancreatic involvement affecting insulin production. Then, assess and manage nutritional needs post-operatively, including early enteral feeding when tolerated to support healing and recovery. Next is provide emotional support to alleviate anxiety and encourage communication about concerns during recovery. Then, educate the patient and caregivers on discharge planning, signs of complications, dietary modifications, and follow-up care. Then, nasogastric tube may be used overnight for stomach decompression. It is usually removed the next day unless output is excessive. Then for the nutritional care, provide small, frequent meals, chew well, avoid lying down immediately after eating, then limit the intake of sugary and fatty foods. And usually, pancreatic enzyme supplements are often prescribed to aid in the digestion. Then, last but not the least is for the wound care. Keep clean and dry, gentle washing with mild soap. Avoid scratching or applying ointments. Then, when coughing, make sure to support the wound. So for the complications, we have the infection, pancreatic fistula, whereas leakage of pancreatic secretions from the anastomosis site, potentially leading to abscess or sepsis. Then, delayed gastric emptying. So this is a common post-operative problem causing nausea, vomiting, and prolonged hospital stay. Hemorrhage, so risk of bleeding intraoperatively or post-operatively due to vascular involvement. Then, respiratory complications, so atelectasis, pneumonia due to pain, limited breathing, and immobility. Then we have thromboembolism, whereas deep vein thrombosis and pulmonary embolism due to prolonged immobility. Then, nutritional deficiencies due to altered digestion and absorption following resection of the digestive organs. Then last but not the least is we have the glycemic instability, whereas resection, as I have said earlier, it can impair insulin production, leading to diabetes or difficulty controlling blood glucose. For the post-operative nursing responsibilities, halos same lang naman siya sa mga nabanggit ko kanina sa mga considerations. So first is we need to monitor and assessment. Of course, hindi mawawala yan. Then pain management, wound and drain care, respiratory care, infection prevention, nutritional and gastrointestinal care, mobilization, and last but not the least is to provide emotional support and education.
Next up, we have laparoscopic pancreatic surgery. Next, we have laparoscopic pancreatic surgery, which is a less invasive type of surgery for treating pancreatic problems. Instead of making a large cut, doctors make small incisions in the abdomen, and through the small cuts, they insert a camera and special tools to perform the surgery. This technique allows for more precise operations and faster recovery compared to traditional open surgery. It's commonly used to remove tumors, cysts, or damaged pancreatic tissue with minimal disruption.
Here are the 5 types of laparoscopic pancreatic surgery, and don't worry, I'll keep it super simple. First, laparoscopic distal pancreatectomy, where the doctor removes the end part of the pancreas, the tail, and the body, and they usually leave the spleen untouched, like trimming off the bad part of a fruit. Second, laparoscopic Whipple or the pancreaticoduodenectomy, and this surgery removes the front part of the pancreas or the head, plus the gallbladder, part of stomach, small intestine, and it is used for serious issues like cancers. And the third is laparoscopic enucleation. Doctors take out only a small amount of lump or tumor, not the whole pancreas, like picking out a seed without harming the fruit. Let's continue exploring laparoscopic pancreatic surgeries. These techniques are less invasive and help people recover faster. For number 4, laparoscopic drainage of pancreatic pseudocysts, and this surgery is used when fluid collects in the pancreas due to pancreatitis. Instead of a large incision, doctors use small cuts to drain this fluid, helping relieve pressure and symptoms. And lastly, laparoscopic pancreatic necrosectomy. In cases of severe pancreatitis, part of pancreas can die, and this can cause infection. And laparoscopic pancreatic necrosectomy involves removing the dead tissue or the dead part, helping the rest of the pancreas recover and prevent complication. These surgeries are perfect example of how modern techniques are making pancreatic treatments safer and quicker.
So next, we're going to tackle about the difference between the Whipple procedure versus the laparoscopic one. So for the difference, the Whipple procedure is a big complex surgery. Doctors remove the head of the pancreas and other parts of nearby organs like small intestine, gallbladder, and stomach. It's usually done when someone has pancreatic cancer or a serious condition. On the other hand, for laparoscopic pancreatic surgery, it is much gentler. Doctors use small cuts and tiny tools to treat less serious problems like non-cancerous tumors or cysts. It's quicker, less painful, and patients recover faster. So in short, Whipple for serious cases and involves more organs, while laparoscopic surgery is less invasive and used for milder conditions.
Preparing for surgery is crucial to ensure patient safety and smooth operation. First, what we are gonna do is assess and review. Start by conducting a thorough physical and psychosocial assessment. This means we're gonna do checking. We're gonna check the patient's overall health, emotional state, readiness for surgery. Next is we're gonna review labs like CBC to check blood health, coagulation test to ensure proper clotting, and liver function test, which is also called LFTs. Next is we're gonna analyze imaging results and medical history to identify risk. Second, patient education. Explain everything clearly and simple. The procedure itself and what it involves. NPO, nothing per orem or nothing by mouth. Requirements, no food or drink for 6 to 8 hours before surgery. And we're gonna also tell that what recovery might look like, including the pain management strategies. For the third, the pre-op preparations. Confirm the patient has followed the NPO instruction. Ensure all necessary consent are signed. Start an IV line for fluids or medication. And administered any pre-op medication as ordered by physician. And fourth, psychological support. Address the patient's anxiety by listening to their concerns, offering reassurance, let them know that they are in good hands and what to expect during and after surgery. A smooth preoperative process set the stage for a successful surgery. Assess thoroughly, prepare diligently, educate clearly, and support the patient emotionally.
Next, for intraoperative, first we have to assess with positioning. One of the first tasks is positioning the patient correctly on the operating table. This ensures that the surgeon has the best access to the pancreas while keeping the patient comfortable and safe. The patient is placed carefully to prevent pressure injuries like bed sores that can happen if the skin is pressed too long. Padding is also used under bony areas like elbows and heels for extra protection. Second, we have to maintain sterile technique. Everyone in the operating room wears gloves, masks, and gowns to keep germs out. Now, our job is to double check that everything stays sterile to avoid infections. If something gets contaminated, let the team know immediately. Third, we have to monitor the vital signs and document events. We have to keep an eye on the vital signs like heart rate, blood pressure, and oxygen levels. If something changes, report it right away because quick action can make all the difference. Additionally, we have to write down any events during the surgery. This creates a record for the surgical team to review later on. Last but not the least, we have to assist with tools and counts. Laparoscopic surgery uses special tools like tiny cameras and instruments. Now remember, we have to position carefully, stay sterile, monitor closely, and count accurately. Each step contributes to a successful operation and a healthier patient.
After surgery, carefully monitoring and support are essential to help the patient recover smoothly. What we are gonna do is first monitor and assess. Regularly check vital signs like heart rate, blood pressure, and temperature. Next is we're gonna assess the patient pain level and make sure that they are comfortable. Next, inspect the incision site for redness, swelling, drainage, and check for the output for any surgical drains. Second is the pain management. Administered pain medication as prescribed and evaluate its effectiveness. Adjust the pain control strategies as needed to ensure that the patient is at ease. Third is early ambulation. Encourage the patient to start moving as soon as possible. Walking helps prevent blood clots or what they call thromboembolism, and it also improves breathing to avoid respiratory complication. Fourth, diet progression. Start with clear liquids and gradually introduce solid food at the patient tolerated. Next is monitor for nausea, vomiting, or difficulty in digesting food. Adjust the plan as necessary for the patient needs. And fifth is watch out for any complications. Be alert for fever, increasing abdominal pain, excessive drainage, or signs of infection at the incision site. Report any concerning changes immediately to the doctor or the nurses on duty. Six is patient education. Teach proper wound care. Include keeping the incisions clean and dry. Explain the signs of complications to watch out for, like redness, swelling, or unusual drainage. Provide clear guidance on activity restrictions such as avoiding heavy lifting and review through the follow-up schedule. And post-operative care is about monitoring closely, managing pain, and guiding recovery. With the right support, patient can heal safely and return to normal activities.
Laparoscopic pancreatic surgery is generally safe, but complications can happen. First, we have pancreatic fistula. This is a leak of pancreatic fluid that can cause abdominal pain or infection. Next, we have DVT or deep vein thrombosis or pulmonary embolism, wherein blood clots can form in the legs, or DVT or travel to the lungs or pulmonary embolism, causing swelling, pain, or difficulty breathing. Next, we have bleeding or hemorrhage. Excessive bleeding may occur during or after surgery. Next, we have fourth, for delayed gastric emptying. The stomach may take longer to empty, leading to nausea or vomiting. Fifth, we have wound infection. Signs like redness, swelling, or pus at the incision site should be treated promptly with antibiotics. Sixth, we have intra-abdominal abscess or infection. An infection within the abdomen can cause fever and pain. And seventh, we have exocrine or endocrine insufficiency. The pancreas may not work as well post surgery, causing digestion issues or diabetes. These are managed with enzymes or insulin. We have to recognize complications early to manage them. We have to stay alert to symptoms and act quickly to ensure patient recovery.
For our patient, here are our nursing responsibilities. First, ensure preoperative preparation is complete, checking the consent, laboratory, fasting, or the NPO status of the patient. Second, provide emotional support and clear communication to reduce fear and anxiety. Third, monitor and document patient status throughout the perioperative phases. Fourth, manage pain and prevent complications such as infection and thrombosis. Fifth, educate the patient and family on recovery expectations, nutrition, and self-care. And lastly, coordinate with interdisciplinary team for safe discharge planning. Of course, before we end it, here is the pop-up quiz. What is the minimally invasive surgical technique used to treat various pancreatic conditions such as draining pseudocysts or removing tissues? Here are the choices. A. Open surgery. B. Laparoscopic surgery. C. Radiation therapy. Or D. Chemotherapy. The correct answer is letter B. Laparoscopic surgery. It uses small cuts and a camera to perform the surgery with less pain and faster recovery.
Good day, everyone. So, I'm Armin G. Abunda, and today I'll be discussing the beggar procedure, also known as duodenum preserving pancreatic head resection or DPPHR. So, this procedure, developed by Hans G. Beger in the 1980s, is aimed at treating chronic pancreatitis localized to the head of the pancreas. So, its primary goals are to relieve pain and preserve pancreatic function, all while avoiding the need for a full pancreaticoduodenectomy. Let's explore this procedure in more detail. The bigger procedure is specifically designed to address the fibrotic mass in the pancreatic head that results from chronic pancreatitis. By performing this surgery, we aim to relieve the persistent pain that many patients suffer from while also preserving the endocrine function such as insulin production and exocrine function, which is responsible for digestive enzyme secretion. Unlike traditional pancreatic surgeries, the Beger procedure avoids the need to remove the duodenum and common bile duct, which helps preserve the patient's overall digestive system.
Now I'm going to discuss about the two main types of Berger procedure. First, the classic Berger procedure. It involves transecting the pancreas over the portal vein and removing the entire pancreatic head. Despite the resection, the duodenum is preserved, which helps avoid the more extensive resection involved in procedures like the Whipple operation. After the head is removed, reconstruction is performed by connecting the remaining part of the pancreas to the jejunum, a process called pancreaticojejunostomy. This procedure is effective for relieving chronic pain and decompressing the bile and pancreatic ducts. However, it requires precise surgical technique due to the proximity of the major blood vessels like the portal vein. On the other hand, the modified Beger procedure is a more conservative and tailored version of the classic technique. Instead of fully transecting the pancreas or removing the entire head, the surgeon performs a partial resection or coring out of only the diseased portions of the pancreatic head. This approach avoids complete transection over the portal vein, which reduces surgical risk, especially in patients with severe inflammation or complicated anatomy. Key structures like the duodenum, common bile duct, and blood vessels are carefully preserved, and reconstruction is similarly done by creating a connection between the remaining pancreas and the jejunum, or in some cases, the stomach. The modified Beger procedure is especially beneficial in reducing operative time, minimizing blood loss, and preserving as much as much healthy pancreatic tissue as possible. It still provides pain relief and functional preservation with fewer complications compared to more radical procedures.
Now, let's proceed with the preoperative considerations. Before the procedure, several preoperative measures are crucial for ensuring the best surgical outcome. First is imaging studies. Advanced imaging such as MRI or magnetic resonance imaging, MRCP or magnetic resonance cholangiopancreatography, or CECT or contrast enhanced computed tomography plays a crucial role in surgical planning. These modalities help in accurately assessing the extent of pancreatic head inflammation, ductal dilation, and in ruling out differential diagnoses such as malignancy. Imaging also assists in evaluating anatomical variations and identifying any vascular involvement that may influence the surgical approach. The second one is pancreatic function assessment. Both exocrine and endocrine functions of the pancreas must be evaluated preoperatively. Chronic pancreatitis often leads to decreased production of digestive enzymes, which is exocrine insufficiency, and impaired insulin secretion, which is endocrine dysfunction, which can result in malabsorption, weight loss, and diabetes mellitus. Function tests may include fecal elastase 1 serum glucose and HbA1c levels. Preoperative glycemic control and enzyme replacement therapy may be initiated if necessary to stabilize the patient prior to surgery. The third one is nutritional status. Patients with chronic pancreatitis commonly suffer from protein calorie malnutrition and fat soluble vitamin deficiencies, specifically vitamins A, D, E, and K. This is due to poor dietary intake, chronic inflammation, and malabsorption. A comprehensive nutritional assessment including serum albumin, prealbumin, transferrin, and micronutrient levels should be performed. Nutritional support such as high protein diet, enteral nutrition or TPN in severe cases, and supplementation should be provided to optimize tissue healing, immune function, and post-operative recovery. The fourth one is informed consent and risk discussion. Clear communication with the patient and family is critical. A detailed informed consent process should explain the nature of the procedure, expected outcomes, and potential complications such as pancreatic fistula, delayed gastric emptying, hemorrhage, infection, and endocrine or exocrine insufficiency. Discussion should also include the possibility of conversion to a more extensive surgery if complications or unexpected findings arise intraoperatively. Emotional support and patient education help reduce anxiety and improve cooperation during the perioperative period. The fifth one is pain management and preoperative optimization. Patients with chronic pancreatitis typically present with chronic abdominal pain. A multimodal pain management strategy should be in place before surgery, potentially including non-opioid analgesics, nerve blocks, or neuropathic pain medications. Preoperative management of other comorbidities such as diabetes, cardiovascular disease, or substance use is also important to reduce perioperative risk. Last but not least, anesthesia evaluation and optimization. A thorough pre-anesthetic assessment should be conducted to evaluate airway status, cardiopulmonary function, and prior anesthetic history. Chronic inflammation, malnutrition, and chronic opioid use may alter the patient's response to anesthesia. Plans should be made for intraoperative fluid management, monitoring of blood glucose levels, and prevention of potential complications such as hypotension or hypoglycemia.
For the intraoperative nursing considerations, during the Beggar procedure, the patient is positioned supine with proper padding to prevent nerve injury. In the upper abdominal area is prep and drape using strict sterile technique. Nurses prepare essential instruments including abdominal and vascular sets, suction, electrocautery, hemostatic agents, and vascular clamps due to the proximity of major vessels. Throughout the operation, nurses assist in monitoring vital signs and fluid balance, track estimated blood loss, ensure blood products are available, and communicate any significant intraoperative changes to the team. Also, strict aseptic technique must be maintained throughout the procedure to prevent infection, and it is essential to confirm that prophylactic antibiotics have given before the incision. Nurses must anticipate the surgeon's needs, especially for reconstructive steps like pancreaticojejunostomy or pancreaticogastrostomy, by preparing sutures, drains, and appropriate instruments in advance. Accurate documentation is also vital, including the time of incision and closure, sponge and instrument counts, specimen handling, and any intraoperative complications or changes.
Now, in the risky procedures such as the classic burger, there is a risk of leakage, pancreatic leakage, since we cut to the portal vein. If it's not resectioned carefully and thoroughly, it might leak some fluid. That's why we have to maintain the drains, to monitor the drains and watch out for any signs of uh, leakage and fluid reabsorption in the abdomen. Because of the uh, because of the procedure, it might cause an inflammation in the pancreas. Pancreas is known to produce islet cells that manages our sugar. So, to manage this, we have to monitor the blood sugar regularly to see if the patient's blood sugar is stable. Now, if the blood sugar is not stable, it might cause further complications if not managed. Most surgical procedure requires a thorough managed diet and nutrition. First and foremost is the anesthesia. Without any signs of bowel movement, we cannot eat. Now, it's given that any diet must come from soft diet to hard diet slowly to support the supplements and the reproduction of enzymes to break down food. So, yeah. It's very common that we do a patient monitoring whenever we do a surgical procedure because we have to watch out for the signs and symptoms that may exacerbate the problems of the procedures. These are the common complications that associated with the Berger procedure. We have the pancreatic fistula, which is the uncalled fistulation of the portal veins. We have the commonly postoperative hemorrhage if the wound is not closing down, and especially when the blood sugar rises and won't be able to close down it by itself because of the unstable blood sugar. Now we have delayed gastric emptying. Well, any abdominal procedures may cause a chronic or delayed gastric gastric movement. And we have the post-operative diabetes. Resectioning may cause inflammation in the pancreas, and which means it could inhibit the production of the islet cells and develop into a diabetes. And lastly, the chronic exocrine and endocrine dysfunction. This is the last and worst that could happen. It means the procedure only exacerbated the conditions of the of any disease that is related to the pancreas. As any other procedure, we have to monitor the fluid and the pain. Any person that undergone a surgical invasive procedures may experience pain. That's why we have to monitor pain to help and alleviate the patient's distress and provide comfort. Wound care is given to any incision or wound to clean. And for the, of course, the afterwards is the patient must be able to help themselves and be independent too by helping them to health education.
Now let's talk about the Frey procedure. The Frey procedure is introduced by Dr. Charles Frey in 1987 and is used to treat chronic pancreatitis, especially in patients with inflammation in the pancreatic head in a dilated pancreatic duct. This procedure involves carving out the inflamed pancreatic head and creating a longitudinal pancreatic jejunostomy to improve drainage and relieve pain. Unlike the beggar procedure, it does not involve cutting through the neck of the pancreas, making it less invasive.
For the fray procedures, we have the open fray procedure. It's a standard that involves immediate incision. Technically, we're going to have an open surgery using a large midline incision to open and see the insides of the pancreas. And the other one is the laparoscopic fray procedure, which is a minimally invasive alternative. It uses a laparoscope to see and view. It's like a camera inside. It's just gonna make a small incision so that it's minimally invasive, but it's technically much more challenging because it has a limited vision rather than the open fray procedure. For the preoperative consideration, we have to make sure that there's a proper imaging, CT scan, MRI, just to complete the diagnosis. And from that, we have to consider the pain and nutrition of the patient. We cannot undergo the procedure if the patient is experiencing a onset of symptoms, especially when it actually exacerbated. Now, most of the patients that have problems with their pancreas actually have other comorbidities like liver problems, spleen functions, and actually GERD and the rest. So we have to manage those and to consider that prior to the procedure, especially the kidney ones. There are one being susceptible. And then for the pre-operative, it's always given that we have to educate our patient, we have to instruct them, and they must know what kind of procedure they're undergoing, and to ensure that the consent is proper and well informed. So we call it the informed consent.
Now, let us proceed with the intraoperative considerations of fray procedure. First, patient positioning and exposure. Intraoperatively, proper positioning in supine position and exposure, midline incision, and entry into the lesser sac are critical to access the pancreas safely and effectively. Adequate visualization helps avoid injury to surrounding organs and vessels, especially in patients with dense adhesions or distorted anatomy due to chronic inflammation. Second, coring out the pancreatic head. This is the central surgical maneuver of the fray procedure. It is performed intraoperatively to remove the diseased tissue while preserving key structures like the duodenum and nearby vasculature. The extent of coring is determined based on real-time assessment of the pancreas's consistency and degree of fibrosis, which cannot be fully appreciated until the abdomen is open. Third, pancreatic duct incision. This step is done during surgery based on the actual intraoperative findings of ductal dilation. The duct is opened along its length to relieve pressure, remove obstructions, and allow drainage. The surgeon may need to adjust the length or location of the ductotomy depending on what is visualized in the operative field. Last but not least, Roux-en-Y reconstruction. This reconstruction is planned preoperatively but performed intraoperatively based on the extent of head resection and ductotomy. The decision on how long to make the Roux limb, how to orient it antelecolic versus retrocolic, and how to anastomose it to the pancreas is made during the operation, depending on anatomical factors and ease of tension and free connection.
After the fray procedure, several key post-operative considerations are essential to support patient recovery and prevent complications. First, drain and leak monitoring is crucial. Nurses and the surgical team must regularly observe for signs of pancreatic leaks or abscess formation, which may present as fever, abdominal pain, or unusual drain output. Early detection can prevent severe infections and promote healing. Next is diet progression. Patients typically begin with clear liquids and gradually transition to a soft, low-fat diet as tolerated. This helps minimize pancreatic stimulation and supports digestive recovery. Pain control is another priority. Depending on the patient's condition, this may involve the use of opioids or a multimodal approach, including non-opioid analgesics to manage pain effectively while reducing opioid-related side effects. Lastly, we must monitor for changes in pancreatic function since the procedure may affect the pancreas' ability to produce digestive enzymes or insulin. It is important to assess for signs of exocrine or endocrine insufficiency, such as malabsorption or unstable blood glucose levels, and manage them accordingly.
As with any major abdominal surgery, particularly involving the pancreas, the free procedure carries a number of potential post-operative complications. These arise due to the pancreas's fragile nature, its role in enzymatic secretion, and its proximity to major vascular and digestive structures. First complication is pancreatic fistula. This develops when pancreatic secretions leak from the surgical anastomosis or the resected surface of the pancreatic head. These enzyme-rich fluids can auto-digest surrounding tissues, leading to localized inflammation, infection, and even erosion into adjacent blood vessels. Fistulas are often classified based on the output volume and enzyme content of the drainage fluid. Persistent fistulas can prolong hospital stay, delay wound healing, and necessitate percutaneous or surgical intervention. Second complication is the intra-abdominal hemorrhage. Hemorrhage is a serious risk due to the pancreas's close proximity to major vessels like the superior mesenteric vein, portal vein, and splenic vessels. During coring of the pancreatic head or ductal incision, injury to small or major vessels can result in significant intra-abdominal bleeding. Post-operative hemorrhage may present acutely or as a delayed complication due to vessel erosion or pseudoaneurysm formation. This can lead to hemodynamic instability, hypovolemic shock, and in severe cases, necessitate reoperation or embolization. Third complication is the DGE or delayed gastric emptying. DGE is a functional complication where gastric motility is impaired, leading to nausea, vomiting, bloating, and inability to tolerate oral intake. It is believed to be caused by post-operative inflammation near the duodenum or disruption of vagal nerve fibers during surgical manipulation. DGE often resolves with supportive care but can significantly impact nutritional status and recovery. Prolonged cases may require nasogastric decompression or prokinetic therapy. Fourth complication is the abdominal infection or abscess formation. Infection may result from contamination during surgery, leakage of pancreatic fluids, or necrosis of pancreatic tissue. Localized collections of infected fluid can form especially near the site of anastomosis or coring. These may present with fever, localized tenderness, leukocytosis, and elevated inflammatory markers. Management may involve antibiotics, image-guided drainage, or surgical debridement. Severe infections can escalate to peritonitis or sepsis. Last complication is the chronic exocrine and endocrine dysfunction. Despite efforts to preserve pancreatic tissue, some patients develop long-term dysfunction. Exocrine insufficiency leads to poor digestion, steatorrhea, and weight loss due to insufficient production of digestive enzymes. On the other hand, endocrine dysfunction can result in impaired insulin secretion, leading to new onset or worsened diabetes mellitus. The risk increases with extensive fibrosis, repeated inflammation, or inadequate residual pancreatic function after surgery. Lifelong enzyme replacement or insulin therapy may be required. Post-operative nursing care plays a critical role in ensuring a smooth recovery and in preventing or managing complications. The following nursing responsibilities are essential in providing safe and effective care to patients who have undergone the Frey procedure for chronic pancreatitis. First is the drain monitoring. Vigilant monitoring of surgical drains is vital, particularly in the first few post-operative days. The pancreas produces enzyme-rich fluids that, if leaked, can lead to fistula formation or intra-abdominal abscesses. Nurses must assess the color, volume, and consistency of drainage fluid, with particular attention to elevated amylase levels that may indicate pancreatic leakage. Timely detection can guide interventions such as prolonged drainage, imaging studies, or adjustments in nutrition and antibiotic therapy. The second nursing responsibility is wound care and infection prevention. Surgical wounds must be cared for with strict aseptic technique to minimize the risk of surgical site infection. This is especially important in abdominal surgeries where contamination from gastrointestinal flora can occur. Nurses are responsible for regular inspection of the wound, dressing changes, and monitoring for signs of infection such as redness, swelling, warmth, or purulent discharge. Prompt identification and treatment of wound infections help prevent deeper tissue involvement and systemic spread. The third one is the glycemic monitoring and enzyme support. Because the Frey procedure may impact both endocrine and exocrine functions of the pancreas, nurses play a critical role in monitoring blood glucose levels and recognizing signs of hypo or hyperglycemia. This is particularly important for patients with a history of pancreatitis-induced diabetes or those at risk due to reduced pancreatic tissue. Additionally, pancreatic enzyme replacement therapy or PERT may be initiated to support digestion and prevent malnutrition. Nurses must observe for signs of steatorrhea or weight loss that indicate enzyme insufficiency. For the last nursing responsibility, patient education and discharge planning. Before discharge, comprehensive education is essential to empower patients to manage their condition effectively at home. Nurses should provide instructions on dietary modifications such as low-fat and small frequent meals, proper use of enzyme supplements, and blood glucose self-monitoring techniques if diabetes is present. Patients should also be informed about the importance of hydration, recognizing signs of infection, and following up with outpatient care. Proper discharge planning supports long-term recovery and helps reduce the risk of hospital readmission. Thank you for listening. I hope you learned a lot in our report.